Good afternoon, everyone, and welcome to today's webinar, An Introduction to Simulation-Based Learning. My name is Siddharth Joshi, and I'm an industrial designer and a communication strategist at Laerdal Global Health. I'll also be your moderator for the session today. Before we go ahead, let's quickly go over the agenda for the day. We have 2 simulation-based films which we'll be launching today, and we have 4 excellent presentations by leaders in the field of simulation-based education in India. And at the end of it, there'll be a Q&A session where we'll be answering your questions. The first agenda is actually the first simulation film. It's a 3-minute introduction to what is simulation.
Simulation is an education technique that mimics real-life scenarios in a safe learning environment and helps to develop provider competency. Simulation-based training is a bridge between cognitive skills-based learning and real-life clinical experience. It is beneficial for obtaining essential skills and develop critical thinking needed for competent healthcare providers, be it doctors, nurses, midwives, or paramedics. Simulation sessions typically consist of pre-briefing the case, running the scenario, and debriefing. Using real-life case scenarios, learners are faced with typical situations they would encounter in clinical practice. Performance is then reflected upon for future improvements during the debriefing sessions. Learning in a clinical setting at the outset poses risks. Also, in a real emergency situation, it is bound to be difficult to teach and learn when the primary focus is on life-saving. In addition to frequently seen cases, simulation provides exposure to rare diseases, critical cases, near misses, and crisis situations that may not be experienced during clinical training. It helps to develop practical skills, clinical reasoning, and integrates theory with communication techniques. The most important part of simulation is debriefing, since the most valuable learning opportunities are largely presented during these sessions. By reflecting on their own performance, learners gain powerful insights into their actions, how they work, and how they communicate. Debriefing also helps to reinforce learning objectives and to identify where improvements can be made. It is important to note that the debrief is not about an individual, it is always about the team.
We need to see a difference because at the end of the training, no matter what kind of training we give, it will only be measured by the success at the bedside.
Simulation helps in each person knowing what is going to be their roles in that situation. That's why the simulation trainings help, because then you have to work as a team.
In health, the major challenge is basically trained manpower. So if you have a very good team, you can really produce great results.
One professional cannot help or save lives. It is a team which is very, very important. If there is a preparedness, it's no more an emergency.
Now moving on with the presentation. Our first presenter for the day is Unni. Unni Silkoset is the Regional Director for South Asia for Laerdal Medical and Laerdal Global Health. Her main responsibility is to strengthen the Indian organization for India to become the hub of the region. Prior to joining Laerdal, Unni worked at the Norwegian Embassy in New Delhi as a counselor, responsible for the health portfolio. She worked on projects related to maternal and neonatal health and for the facilitation of Norwegian and Indian health cooperation. Unni has also worked for UNICEF in Asia and Africa with health and nutrition projects. Unni holds an MBA from BI Norwegian Business School and an MSc in Public Health and Nutrition from Oslo University. Unni will be joined by Dr. Rashmi Aradhya. Dr. Rashmi is Program Implementation Manager Asia for Laerdal Global Health. Over to you now, Unni.
Thank you very much, Sid. So Laerdal is a global company headquartered in Norway. We work around 3 focus areas. The first one is resuscitation. The Utstein formula for survival shows that survival depends upon 3 factors: medical science, educational efficiency, and local implementation. With internet and open source publications, there is now little difference in the medical science knowledge. However, there is a big difference in educational efficiency. The quality of CPR, the use of simulation and role play in capacity building, and low-dose high-frequency trainings are all important for developing and retaining skills. Also, in the local implementation, there are big variations. Whether cardiac arrests are being registered, how dispatchers guide the bystander to carry out CPR, how quickly the ambulance arrives, and how cases are reviewed for learning differ greatly between the areas in the world with the highest and the lowest survival rates. A second focus area for us is maternal and newborn health. Together with a range of international and local partners, we have developed a suite of 8 training programs. These are now implemented in more than 80 countries with good results. Common for both resuscitation and maternal and newborn health is our support to simulation-based education, which is our third focus area and topic of today's webinar. As you saw in the film, simulation-based education is part of the circle of learning. It is important to understand that in order to conduct effective simulations, having adequate knowledge and also skills proficiency are both important. There is now more and more evidence on how simulation-based education improves clinical practices at the bedside. Here is a list of 10 practices that are important and interlinked for successful outcomes of simulation. We see that reflective debriefing, regular refresher trainings, a range of difficulty and quality simulators are all part of these 10 practices. For Laerdal, partnerships with global and local institutions are key to achieve our ambitious goal of helping save 500,000 more lives by 2020 every year. We hope that all of you who are listening in today will be part of this meaningful journey with us in India. I will now hand over to my colleague, Dr. Rashmi.
Thank you, Unni. Continuing on the very important study which Unni just highlighted about the 10 best practices in simulation-based education, I would highlight some of these practices already taking shape in India. What you're seeing now on your screen is a picture of Ayush as a 3-month-old baby. He didn't cry after he was born, something his mother recounts as a very painful experience. But the nurses who delivered him helped him breathe by resuscitating him during the crucial first minute after birth, the golden minute. Ayush not just survived, but has thrived. The picture that you're seeing on the right side of your screen is Ayush now. He is 3 years old and has met every development milestone on time. It was made possible due to the providers at the facility practicing resuscitation skills daily for 1 minute. That's low-dose, high-frequency refresher training. Integration into curriculum, which is one of the one of the 10 best practices just mentioned. The Ministry of Health and Family Welfare has been taking steps to include skills practice and simulation-based education into pre-service and in-service trainings for improving patient care. Skills labs are now becoming a norm. We are working with the Ministry of Health and Family Welfare, Indian Nursing Council, Jhpiego, to include simulation-based education into skills labs and into curriculum, both in in-service and pre-service trainings. As an extension of the same, we are also collaborating with the government to help achieve Family Planning 2020 goals. The uterus collection, which is a modular training mannequin, and it was specifically designed in India for India to help make trainings simpler to teach, to understand, and improve practices. This was done with continued engagement with the family planning experts in India, the ministry, and the users on the field. The uterus collection is about to be launched. A recent landmark study by the American National Council of State Boards of Nursing shows that up to 50% of clinical hours can be replaced by high-quality simulation in pre-licensure nursing curriculum. The key words here are high-quality simulation. Simulation itself is not the goal, but it must be measured by improved patient care, improved patient outcomes, and the lives saved. Thank you.
Thank you so much, Rashmi and Unni. Moving on, let me introduce to you the second presenter for the day. A medical doctor by qualification with a master's degree in public health from the London School of Hygiene and Tropical Medicine, Dr. Somesh Kumar is the head of programs and deputy country director at Jhpiego's India office. He has extensive national and international experience as senior technical advisor to public health groups. Dr. Kumar leads Jhpiego India's programs in human resource for health, programs which are holistically addressing and contributing to the revitalization of the nursing cadre in the country. He'll be sharing insights on the largest rollout program for nurse mentoring in India by Jhpiego and how simulation plays a huge role in it. Over to you, Dr. Somesh.
So I'll be talking about taking the cue from Unni and Rashmi forward. I'll be using the learnings of Jhpiego's experiences of implementing large-scale competency-based training programs, which are a part of initiation or standardization of clinical services in both private and public sector facilities of India, and how we have used simulation and case-based practice to ensure that the trainings have been quality and they have resulted in an improvement of practices going forward in a lot of private and public sector facilities. So, the guiding principles based on our learnings are as follows. First, there's a lot of talk around what is the dosage and ideal dosage or frequency of trainings. A lot of talk on low dose high frequencies or low dose frequencies. These kind of terminologies have been used increasingly in our technical parlance these days. So based on our learnings, we really feel that there is no one normative approach to delivery of trainings related to both dosing and spacing and even the frequency of the trainings. And the dosage and frequency would depend both on the system or the person who is delivering the training, and also the person or the providers that are supposed to receive that training. So based on our experience, we feel that since the contexts are so different and the providers are so different from place to place, the dosage and frequency needs to be calibrated by the system who is delivering the service trainings based on, one, the type of clinical skills to be important. Is it a new skill for the provider concerned, or is it just a standardization of the existing skill of the provider? Then also the baseline competency level, and the cadre of the provider. So if it is a task shifting that we are talking about, it will have an implication on the dosage and frequencies of the trainings to be imparted. And if it is, or even if it is, we are talking about training an obstetrician or a pediatrician, that rather than a staff nurse or a midwife, all of this has an implication on the titration of the dosage and the frequencies during the planning of these trainings. Then, in addition to the receiver of the training, the capacity, both management and technical capacity of the system which is to deliver the trainings has also to be factored in, because ideally you would want each the trainings to be reduced to as low as possible over long periods of time. But since we are working in public health context and at scale, with a lot of resource constraints, we have to be aware about the capacity of the system to deliver that training. And so really a careful balance of the capacity and the optimum level of trainings that are to be required have to be attempted during the design of the training program. And finally, the dosage and frequency will also increase or depend on the client load and the preparedness of the training site where the trainings will be imparted. So we also, some other guiding principles based on our learnings are, first, we should, in today's resource constrained settings that we work in, training should be taken as close to the provider as possible, because it's very important that you don't disrupt the services at facilities which are already resource constrained. And additionally, it also eases the provider to, if he or she is in their context during the training sessions, which are to be planned as a part of public health programming. Secondly, initiation of training should always be preceded by preparation of the training site. And so what does that mean? That means that you have to first ensure that the clinical practices at the training site where you will be delivering the training, those have to be mature and evolved. And so that the providers or who are coming to those sites for training, they need to be aware about, they need to see the right practices. Then your training system, you should always be geared to always keep on measuring the skills and practices at the trainings at the service delivery sites of the providers you are training. And finally, trainings can, we have felt based on our learnings that to start with a centralized training or a collective training of the concerned providers helps, because it brings all the providers to one location, or to give them a grounding of what are the various competencies that will be covered under a part of this training program over a period of time. But this is just the initial centralized training that we are talking about, which will be followed by low dose, imparting of on-job trainings or skill building at the site going forward. So next, please. So I'll be talking about our experiences on the strategic approach that we have adopted for standardizing MNH competencies in both private and public sector facilities. So for what we typically do is we first identify a training site, which is usually for this purpose a well-functional labor room. But before we start training at that site, we make sure that we train the providers who are working at that training site and work with them to standardize the practices at that training site. Once we do that, we bring the trainees who have to be covered, in optimum batch sizes to this training site for an initial short training covering the key competencies that would be covered, as a part of this training program. And this is followed by, a series of on-site visits for coaching and mentoring of providers through a structured approach. And by a structured approach, I mean that you start with simple skills, mainly knowledge and psychomotor skill related practices during the initial visits on site, and then you follow. You use a lot of simulation and case-based practice at the clinical facilities during these initial on-site visits. As once you have done that and you feel that your providers are able to provide able to adhere to the simple practices that were a part of your clinical practicum, then you proceed to complex skills during the later visits for the on-job trainings. And for the more complex skills, which are not only a function of the psychomotor skills but are also a function of the communication, coordination, and clinical decision-making skills of the providers, you typically use a team-based approach or team-based drills for these skills, which are mostly related to complication management and preparation for complication management and preparation for emergencies at the clinical facilities. So this is the for the low dose iterative training for that we adapt for our MNH competencies. You start with rapport building and knowledge based and psychomotor skills initially, and then you move on to the team centric activities for more complex competencies. So I'll be sharing with you, based on this approach, what have been our, results from some of the trainings that we have been conducting at scale, both in private sector and public sector facilities. So this is the first example is that of, Uttar Pradesh private sector facilities from Uttar Pradesh, 76 of them, where first we did at the baseline you can see that these private sector facilities were on an average achieving around 45% of the 27 clinical standards that were have been proposed as a part of the national guidelines. And so we first did a centralized training that I was talking about, getting all the providers together at a well functional labor room to get them oriented to the various skills that are a part of the training course. And these were followed by a successive exposure of low dose on-site trainings in which each provider was worked with for making sure that the translation of the skill that was given to him in the first or subsequent trainings are happening for practices. So you can see over a period of 22 months as you deliver the short duration of trainings for these facilities, the adherence to practices increases at the facilities from 45% at the baseline to over 80% at the end of 22 months. Similarly, this is an example of Jharkhand at 64 facilities. Same, initial centralized training was provided at baseline. After the baseline was done, which was followed by 11 on-the-job training sessions at site, and you can see a gradual improvement in adherence to practices at these all 64 facilities. And I'm consciously choosing the adherence to practices rather than just the skills, because that's what you ultimately want as a result of any training. So this when we are talking about adherence to practices, this means that as a result of your 11 short or on-the-job trainings, the facilities have improved their performance by adhering to 77% of the prescribed clinical standards at these facilities. So this is now an example of public sector facilities from Odisha, and we are talking about different. I'll give you an example of 4 competencies on how successively the competencies have improved over a period of time. So just for the first competency that I am talking about is assessment or triaging of the woman when she comes to a labor room or to a facility for delivery. And so you need to do some basic practices for assessing the situation of both the fetus and the mother for the type of treatment that is to be provided. And so you can see after the first 2-3 day training that was given, there was very little increase in adherence to practices from for this for practices relevant for the time of admission. So you just increased from 0 to 4%. But after you did you gave 6 doses of on-job short duration trainings, you saw that the adherence to practices improved to 66%. Similarly, for the preterm identification of the newborn during at this time during admission, and appropriate management by antenatal corticosteroids or the other standard practices. Here also you see that you needed at least 6 exposures of low dose on-job trainings to get to a level of 61% adherence to the practices related to preterm identification and management. Now, again, from these very facilities, I'm talking about 3 more practices. The progress of labor, what are the key practice? What is the extent of practices that the provider who were trained during the course of this, delivery of the training programs, how they fared over a period of time. So you again see that following an initial training, the translation of practice happens to a very less level of 7 to 13%. But after you have reached to you have done you have given 6 exposures of low dose on-job trainings, you reach to a level of 45% adherence to this practice, and that applies for both immediate newborn care and active management of third stage of labor also. So based on this, the summary of my message is that based on the context of where you are delivering those trainings, you should always design the training programs based on the capacity of the trainer and the system which is delivering the training, and also the providers who are receiving the training, who are to receive the training. It will be usually a very important, it will involve a lot of balancing between the capacity to deliver training and the best optimum requirement of the providers or the trainees whom you have to train as a part of this training program.
Thank you so much, Dr. Kumar. Moving on, we have a very inspiring speaker coming up right next, Dr. Ramana Rao. Dr. Rao is the Director of Emergency Medicine Learning Center and Research at 108 GVK EMRI, Hyderabad, India. He has also been one of the cheerleaders of the concept of simulation-based learning and has spoken at numerous national and international conferences all through his career. Recently, he also spoke at the TEDx event in Hyderabad. Under Dr. Rao's leadership, over 260,000 individuals have been trained so far, including 12,000 doctors, 42,000 nurses, and in addition, 62,000 paramedics and first responders. Over to you now, Dr. Ramana Rao.
Greetings from 108 GVK Emergency Management Research Institute. Today, very briefly, I'll be talking about the nature of work at this organization with a focus on the simulation education for our very special environment of ambulance-based service. I would also touch upon some of the practices and approaches what we have currently and our future plans with simulation education as a center. So emergency medical services are considered as an extension of emergency departments, and it is a link between the scene to the hospital. Organization of GVK Emergency Management Research Institute for the last 10 years has now expanded to many states in India and in Sri Lanka also, with a fleet of about 11,000 ambulances. And we work with the respective state governments, and we are serving 750 million populations in this country. So emergency management of individual emergencies, multi-casualty instances, and a disaster is a core area of our services. In addition, the EMRI also has a focus on research, which focuses on analytics research, operations research to improve our systems, and clinical research, and the online medical research, which is a very innovative thing where we collect the near real-time data and then we do a follow-up about our services. And finally, the institute part of it is also very, very critical, because we strongly believe that skills save life. And in order to connect an emergency patient, the skills must be available appropriately at the community level, in the ambulance and in the hospitals or the emergency departments. As you would see the photograph of the inside an ambulance, we have two areas. One is the patient compartment area where the emergency medical technician or the paramedic works, and we try to create a critical mass so that the stabilization and the life support treatment can happen while the patient is being transported, what we call en route services. Here one advantage is, while the EMT does the services directly and stabilizes the patient, he can also get the medical direction by a qualified doctor from the centralized emergency response center. So this is how we do this EM is emergency management, research is R, and the I is the institute or the capacity building activities. So people who provide these services are referred as emergency medical technicians. Because we have different types of emergency vehicles and different levels of emergency services we render, depending upon the emergency vehicle, we have a bike EMT, a four-wheeler like an ambulance, regular ambulance. In riverine states of Assam, we have boat ambulances. And depending upon the type of service, we have the basic life support ambulance where the basic EMT works, and we have an advanced EMT, and we have neonatal ambulances where the neonatal EMT works. But there are some areas where the destination, starting and end points are very, very clear, like as in the case of an inter-facility transfer, the ambulance moves from a lower level hospital to a higher level hospital where the IFT EMT works. Same is the case in some of these newly formed initiatives by the government of India under the Janani Sishu Raksha Karyakram. The mother and newborns are transported from the home to the hospital and from hospital to the home, what we call drawback ambulances. So these are these different categories of emergency medical technicians whom we need to train in emergency medical services. So in order to build these cadre of emergency medical technicians, we tried to phase the training program into institutional, hospital, and ambulance phases. And we train them on the professional life support skills as well as the soft skills, which are very, very important in managing the situation, in communicating with the doctor for medical direction, or else communicating with the community family members on scene, en route, and with the healthcare providers and hospital doctors and nurses. We need to be very clear that the emergency medical technician acquired skills at an individual level and at a level what we refer as a proficient level, so that the assessment by leveraging this OSCE methodology will enable that skills are acquired at the individual levels. And we have, in this journey of 10 years, we thought that we should get some standards through recognition, and we have adopted some standards what are being envisaged by the American Heart Association to be an international training center. But we've also believed that collaboration will also enable us to learn a few things quickly which are very pertinent to this discipline of emergency medical services. This is how we have tried to focus the training program and ensure that the skills are available which will result in running operations but result in saving lives as an impact factor. So I just wanted to share some examples today where we use these simulation methods. One of the basic things which is required for life support is an IV access, as in the case of a hemorrhage and shock prevention. And we train our EMTs in IV access, and we use an IV arm for that. They can practice a number of times and before they really go to the hospitals and then start working in the ambulances. You know, similarly, trauma is also another leading area where we help in the EMS. And we use a lot of injuries by the technique called moulage. And sometimes we also talk about amputations and impaled objectives. For all these things we can try to mimic, and we use the simulation method, particularly for the trauma, because when we run these courses for ITLS and our own internal trauma related modules. 1/3 of our beneficiaries are pregnancy women, and then every day we assist about 90 emergency childbirths. In order to create a preparedness among our workforce for these emergency childbirths, we use pelvic mannequins and birth simulators, and it is helping us to ensure that the birth related safety is ensured and both the outcomes in terms of mother and newborn are there by using these birth simulators. We have driving simulators to train our pilots or the drivers, and we also practice using different types of stretchers for our patient transport things. Not only individuals, for group or mass disasters, we use this simulation technique so that the triaging can be learned by all the team members, both the EMT and pilot internally, and when we coordinate with the other important people like police and fire and NDRF, so on and so forth. So far, our experiences in leveraging this important methodology of simulation education enabled us to ensure patient safety. We ensure that each of our workforce acquires any skills which are acceptable, and while at the OSCE methodology, we assume that they get acceptable level of skill acquisition. We pick up some people who are all slow learners, and we adopt this simulation so that there will be a remediation process. When we work with the groups, we know of synergy, communication, and then the coordination has to happen, and then simulation education, we found it to be very useful for the group learning. And we know that skills have got an attrition, and in order to rectify our own workforce, EMTs, we use the simulation method because we work in a very distributed environment in different parts of the country. We internally feel that simulation education can also be tweaked and then bring some changes, and I'm using a word called innovation, and that's what we often use this because every day we have new experiences, and to meet those new experiences we require this simulation, and we leverage that. In future, we wanted to ensure that we have a high fidelity, high technology sim centers also, so that we not only participate in leveraging simulation education, but it can also become a center of excellence, and we can create a cadre of people or instructors who can take advantage of the simulation. And then we wanted to initiate some basic and advanced research activities so that we would be able to measure the outcome and impact of simulation education in EMS. Thank you for your attention. Over to Siddharth.
Thank you so much, Dr. Rao, for such an inspiring talk. Now it's time for the final presentation, and for that, I would like to invite Dr. Rakshay Shetty.
Hi everyone, thank you, Siddharth. All right, so greetings from PediSTARS, and I thank you for giving us this opportunity, and on behalf of PediSTARS, I welcome all of you, those who are listening to this webinar. So I'm going to spend next few minutes on talking about a different role for simulation. What we heard now, very beautiful talks about how simulation can be leveraged as a good training tool. What I want to spend the next few minutes is on how can we use simulation as an intervention to improve our healthcare outcomes, to ensure that the sickest of the children get best of the care. I am a pediatric intensivist. I work in children's hospital, but lots of examples what I'm going to give during my presentation, it could be related to whichever place you might work. It might be in primary healthcare center to a tertiary care center. Now let's try to understand what are the current gaps in our care, right? So one of the biggest challenges what we face is managing sick children at the time of crisis. What we have understood with various studies done over years is it's not just the knowledge aspect of the treating doctor which ultimately determines good outcome. It's also the most important key is ability of doctors and other healthcare professionals from different disciplines to work together as a team at the time of crisis to provide the best care. I'll just come to this in my next slide and describe this in a bit more detail. The second big challenge is being ready to manage emergencies, and oftentimes the infrequent these emergencies are, the less prepared we are. Now this might be taking care of a child in an adult hospital, or it could be in a primary healthcare center, or it could be in a children's hospital. Oftentimes when you're faced with emergencies, that is where we need the maximum preparedness, and how can simulation help? And I'm going to talk about that too for a few minutes. And the last but not the least, we heard a lot about training, but what is very important thing about this training is at the end of the day, when we train, that training has to be linked to outcomes. And then we'll try to look into what are the current fallacies in our training and how can we actually train better to improve outcomes. Now, I just told you that it's not just the knowledge and how smart a physician or a nurse is. It's the ability to work together as a team which ultimately determines the outcome of the patient. Now, oftentimes what happens is if you look at our training, we often train in medical schools, nurses train in nurses schools, technicians train in their own schools. But in the reality, when it comes to managing a child in the hospital or any healthcare facility, we are expected to work together as a team and manage a child, and oftentimes that presents huge challenges. Now, let me give an example of, say, neonatal NRP, or it could be pediatric advanced life support like PALS. Oftentimes, what happens is the doctors go through a training of PALS and then come to the hospital and find it almost impossible to translate what they know at the bedside, because half of their team members don't essentially know what PALS means, don't essentially understand what are those communication principles meant in PALS. And the doctor's knowledge, despite knowing that what he needs to do for a VFib cardiac arrest or what he needs to do for a respiratory distress or a shock, he finds it very difficult to implement the knowledge which he knows at the bedside. And also, there is also fallacy in our training is we focus quite a lot on knowledge, and oftentimes we go to lectures, we listen to this kind of podcasts, we read a lot and acquire a lot of knowledge. We also acquire quite a bit of skills, go to some skill labs, learn how to intubate, learn how to put an IV. But what we actually lack in our training is implementing this knowledge. For example, you might read a lot about respiratory distress, you might go to a lab and learn how to intubate, but the key thing what has to happen at the bedside is identifying someone to have respiratory distress, sick enough to intubate, and intubating them safely. And that's the last part which is actually missing. And simulation here can actually offer a unique advantage. Let's take an example. Now let's take an example that we have a challenge in labor room where you need to attend a delivery of a child. Right? Now, there are various disciplines who are involved. There are obstetricians, there are anesthetists, there are pediatricians, and there are nurses. And oftentimes, if there's a lack of coordination between team members, you can have a bad result. Now, this can happen in the emergency room, might be when a sick child comes, say a respiratory distress. We are expected to work, the nurses and doctors from different disciplines. It could be from emergency physician, an intensivist, or could be an anesthetic person. You're expected to work together, and this kind of creating those kind of situations is possible by using simulation technique. Now you can mimic a delivery of labor in your actual labor room and then learn to work together as a team and address those issues which can improve our coordination so that whatever knowledge is there in the team is executed to the benefit of the child. So the beauty of simulation is now it's not just about exploring your knowledge, but also explores what we call as human factors. Now, human factors are those factors which bridge between knowledge and a clinical reality. So it could be training on situational awareness, could be understanding our environment quite well, or could be about communication. These kind of training is possible with simulation, and in fact, there are many studies which looked into those hospitals which have used team training as a part of their care provision have much better outcomes. People have tried this in labor rooms, people have tried this in emergency rooms, people have tried this in ICU, and whatever the particular challenge in that particular healthcare facility, when they have tried using simulation as a technique to address this issue, they have found better outcomes. Now, I want to talk a bit also about preparedness. Now we know this cricket series happening between Australia and India, and we know that Australian team has already come to India. They're not going to play the test match directly, right? So they've spent some time now playing against India A, and they're also spending a lot of time having net practice. Now think about this, people like Virat Kohli, people like David Warner, they've been playing cricket since their childhood, been training and training and training. They have achieved almost peak of their professional success. But even now, if they were to go for a cricket match, they would not just directly land up in a cricket ground. They would still spend a lot of time practicing. Now, if that were to relate it to us, I mean, that's cricket at the end of the day is a game, but we are dealing with lives. Oftentimes, we go through training and then the training ends as we leave the medical school and then we are expected to practice. Now, think about an example where a surgeon has to operate a complex operation, which he probably does once a year. Now, he doesn't go through a practice like what, say, Virat Kohli does. He just directly goes and operates. Now, think about a possibility where he does that operation on a simulator just before he operates and then operates. So it will be like operating twice but cutting only once. Now, this sounds a bit radical concept. There are certain centers across the world who do this, but then that can be simplified to many things we do at our workplace. Now, for example, the challenge could be that we are finding taking a handover from operating room to an ICU is a challenge, and there's often times we are not well prepared. So if you know that this is a 1-year-old child who's going to come from operating room, you can keep a 1-year-old mannequin and understand who's going to take roles of handover, who's going to stick those monitors, who's going to send labs, and so that when the child comes, you are better prepared. The same thing could be done, for example, dressing any emergency. Let's imagine an emergency of a 2-year-old child with pneumonia needing intubation is going to come to PSU. You can actually run a simulation for 5 minutes on that particular emergency so that everyone knows which child is going to come. So that all these mistakes like not finding a correct size bag and mask, not finding a correct size ET tube, not finding a correct size saturation probe, all those things can be mitigated, can be addressed much before then the child actually enters ICU. Now, these kind of simulations just before a planned event can actually help in preventing many of those errors which can happen at the time of admission. Now, the graph what you're seeing gives a simple example just to reiterate the fact what I spoke about Virat Kohli's example. Now, if you were to take a very unusual, rare skill, for example, let's imagine we learned how to put a pericardial drain. Now, what happens with over time is the pericardial effusion and inserting a pericardial drain is an infrequent skill. You don't come across very often. So what happens with time is your skill actually decays. Now imagine if you were to go through a simulated event every month where you need to insert a pericardial drain. Now if you get a real patient, say 10 months down the line, you will be in much better position than a person who learned it once 10 months back, how to put a pericardial drain. So if you see the graph here, it shows that exposure to these events can keep your skill levels at a very high level. And that is just to speak briefly about how actual simulation can be used as a tool for a better preparedness. We also spoke quite a bit today about training, but think about certain challenges with training. And oftentimes the challenge what we face is a lot of doctors, like the example I gave, they feel that we have done pediatric advanced life support or NRP or for that matter breathe a baby, whatever kind of training it might be. They find it, okay, it's just not possible for me to implement at my workplace. It could be many reasons. They see that, okay, these are the various equipment shown. I don't have these equipments at my workplace. I don't have this kind of manpower at my workplace. I don't think it is possible. Think about shifting this kind of training into actual workplaces. So we're talking about in-situ point of care simulation. So that means you're actually delivering, let's imagine NRP or PALS to that team of doctors and nurses in their working place, in their working environment. And that's more likely to be successful because then they realize how do they actually work with the manpower available to them and equipment available to them. There's also this concept about just-in-time and just-in-place training. What it means is you provide training just before the event and in correct place. Now let me give an example of an ICU. So let's imagine you have a very young nurse and she has to handle a central line. So just beginning of her shift, you have a mannequin with central line, and what the nurse does is she cleans the central line, handles the central line on a mannequin, and then goes on to handle the real central line in a patient. Now there are interventions, studies done on this, and they have shown significant decrease in central line related infections. It could also be that your patient is very sick, potentially might land up having a cardiac arrest. So just before your shift, the nurse actually practices CPR on mannequin so that if there's a cardiac arrest, she's much better prepared to actually perform cardiac arrest. So we are actually tailoring that particular training and thinking about how that training can improve outcomes. And remember, simulation is not always about training. It's also about finding threats in your hospital. So for example, if you were to conduct mock drills or simulation at your workplace, you might actually find, okay, the correct size bag and mask is actually missing, the correct size ET tube is missing from my cart. And that could be because of the fallacies in the hospital policy where it does not replace once items are used. So identifying a lot of these safety threats can actually help you in plugging those safety holes so that your healthcare can be much more safer. I thank you very much for patient hearing, and what we've been trying to do with our PediSTARS journey is essentially trying to figure out how healthcare professionals who are taking care of children can use simulation at their workplace to make the healthcare much more safer and effective. Thank you very much.
Thank you so much, Dr. Rakshay. Now is the time for our final event for the day. It's the launch of the second movie. Sit back and enjoy the film.
Accessibility, affordability, and acceptability are challenges of healthcare delivery system in our country. And India is a country of different cultures, different terrains, different challenges, different health-seeking behaviors.
You know, in health, the major challenge is basically trained manpower. If you have a very good trained manpower, you can do wonders actually.
That a lot of nurses who were coming out from the nursing schools had the knowledge, but they didn't have the competency, they didn't have the skills.
I think the major focus is so much on knowledge accumulation, and people forget that there's a different concept learning.
Traditionally, we used to do trainings in a way where you used to call people at a centralized location, and for convenience of trainers, we used to give them all the information that we wanted to give in one go.
You know, if you try to teach too many skills at one go, then it becomes difficult for the learners. It has to be a low dose, high frequency training.
You break the content into smaller pieces. Give the content at the convenience of the trainees, close to their place, close to the places of practice and their places of residence, and also in doses that they are able to digest and comprehend.
If this drill is being done for doctors, for nurses, then this will bring results in the field. Therefore, we started with the idea of skills lab.
People acquire initial skills, but those skills are lost over time. Skills lab, what has been happening? They have set up a set of mannequins or set up certain sets of equipment, and people are made to practice in batches. It's not a decision-making process.
Skills are acquired at the individual level, and skills are bound to have attrition. Skills is what the hands can do for a healthcare provider. But simulation is an environment of education and training where it is more structured, where a lot of thinking has gone inside.
There's been a lot of greater understanding about the science of learning and recognizing that different people learn in different ways. Some people learn through psychomotor opportunities. Some people learn through experience. Some people learn by practice. And a simulation combines all those things. It kind of meets everybody where they are because it gives everybody a different channel for learning.
In a mannequin, I can teach them, okay, this is the way you do a suction, or this is the way how you put in a tube. Rather than theoretically discussing, they start the treatment, I change my setting, I say, baby has deteriorated. Now what does the person do? Now how do I establish that scenario with visualization? That's what the simulation lab says.
How do we learn to simulate a clinical context? How do I make someone learn how to identify and stabilize a child with respiratory distress? To identify a child to be in shock and teach them how to stabilize them. A lot of us know a lot of things, but they don't get implemented at the bedside. And you talk to them, they say, oh, we knew it, but they just could not implement, or they could not identify. Your learning becomes effective if you experience the event. And there is something called as human factors. This is different from knowledge. So any of those factors, be it environmental, be it with regards to your job, which can alter your thinking and care at the bedside.
First of all, we need to know what the learner actually feels is necessary to improve the situation. See, we all feel that somebody should learn something. So that is what we call a felt need. But deep down, there'll be a real need. Then we need to know who is the target audience. Is it okay if I just teach the doctors? Is it okay if nurses are involved in training? But do most scenarios involve both of them working together? Then the third part of needs assessment probably is where are we going to do it? You can have a nice big workshop in a skills lab, or we could set up everything in a 5-star hotel auditorium and run the session. But there is also some advantage in doing what we call as in-situ simulation. We actually go into the labor ward and we play the same scenario out and then we see.
And simulation is a safe place to learn. You can use the before and the after opportunities to reflect on what worked and what didn't work.
The important session for preparation is that you make sure that you provide a realistic experience. And we want to kind of encourage that reflection by rehearsing or by doing the simulation session, and that you have enough opportunity to actually correct the mistakes if at all any done.
And that is what we call as debriefing. That is the area where we bring out their own experiences and discuss around it.
Simulation learning methodology strongly believes in facilitated learning. The traditional learning has been, I teach, you learn, rather than let us sit together and find out what should be done. We don't label ourselves as a teachers.
We call ourselves as facilitators. We are just facilitating so that that person can learn in a better way.
When it comes to simulation, it is not the technology, it is the technique.
Technology can supplement, but if people think it is a substitute for learning, that is a misconception.
Teamwork. This is one thing which is lagging a lot in our country. We always work as an individual.
Simulation can be used to facilitate and galvanize both team-based learning and team-based practice.
You are only as good as your teams. The doctors train in medical colleges, nurses in nursing schools, technicians in their schools, and they are expected to come together and train, manage a patient. So they are all in their own different zones.
That's where simulation really can help, because simulation allows a team to all be working in their individual roles, but with a unified goal.
And one of the things in health is that it is a team effort. So if you have a very good team, you can really produce great results.
We need to see a difference, because at the end of the training, no matter what kind of training we give, it will only be measured by success at the bedside. How can we make it more effective? How can we make sure that it actually benefits the sickest of the sick?
Simulation can take care of both these bottlenecks of accelerating the pace of training and improving the quality issues.
One professional cannot help or save lives. It is a team which is very, very important. If there is a preparedness, it's no more an emergency. Whenever they are awarded as best lifesaver, they often refer that the training has made them to save more lives. In the center of all these things, the strong link is the science of simulation.
So, dear friends, we have run a little bit over time and we apologize for that. We also welcome feedback on this webinar and suggestions for topics for other webinars on simulation-based education. This was a pilot for us and we would like this to be a series. So your feedback is very much welcome and suggestion for topics. And lastly, just from my end and from the organizers at Laerdal, I want to thank all the presenters today for their wonderful talks, very insightful, and to all the audience who listened in on us. And please join us for future webinars. Thank you so much.